With September being Prostate Cancer Awareness Month, it provides an excellent opportunity to make sure you or your family members are up to date on screenings and knowledge of this disease. And here to help educate us on the diagnosis and treatment of prostate cancer, we have Baptist Medical Group fellowship trained and board certified urologist, Dr. Anthony Avallone. Thanks for being here.
Good morning, Jeff. Thanks for having me.
Well, and welcome to town. I understand you're new to the area. Tell us a little bit about yourself before we get into our subject here.
Sure, I'm new to the area, but actually Pensacola has been our home away from home for over 20 years. And so I'm just thrilled to actually be able to practice here finally.
Well, we're glad you're here on a permanent basis.
Thanks.
So let's get into this. So tell us, for those who may not know, exactly how would you define prostate cancer and how is it detected?
So prostate cancer in some ways is very similar to breast cancer. When it's early and potentially curable, there's no symptoms. So I initially trained in residency before the PSA era came in, and it wasn't uncommon in those days that someone would come in with metastatic prostate cancer. And once it spreads, it's an incurable disease. So in the late 80s, we had this test come around called PSA, and that's helped us find prostate cancer earlier when it's potentially curable before there's symptoms. And we use it very similar to the way mammograms are used to detect breast cancer.
Mm-hmm. Well, it sounds like a very beneficial screening. How do you explain that and get your patients on board with understanding the benefit to doing that?
So I explained to them it's a simple test, it's just a blood test, and as I mentioned, it's used very similarly to mammograms for detecting breast cancer in women.
Now, is that a blood test that can be done when people are doing other, say, annual blood work, or is this something specific they would need to schedule?
No, they could add it onto their other blood work. You don't need to be fasting. It's an easy test.
Okay. Well, hopefully that can be avoided, but in the case that it's not, what are some of the treatment options?
So for localized prostate cancer, that is prostate cancer that's still confined to the prostate and potentially curable, the two main treatment options are radiation techniques and surgical techniques. And we really individualize it based on a patient's other health issues. We call them comorbidities, their age. We treat prostate cancer patients that are in their 40s to men that are, in their advanced age. But the typical age that we treat localized prostate cancer is 40s to early 70s.
So when you mention those ages, are there some people that don't require, or maybe treatment is not an option that you go forward with?
Yeah, absolutely. So one of the things that we found with screening with PSA, we pick up what we call latent prostate cancer in some patients. So prostate cancer can take two forms: a clinical disease that can be very dangerous and lead to your death if untreated, but there's also a latent form of the disease that we all get as we get older. And as we've made progress in separating the two, we don't have all the answers, but there's definitely a set of prostate cancer patients that don't actually need treatment. And so in those patients, we either pursue what we call watchful waiting or active surveillance.
Okay, well, explain what the difference is for those two terms.
So watchful waiting is if we have an elderly patient, say someone in their 80s, and we detect prostate cancer can be slow growing. So in those patients who have the slow growing type of prostate cancer, we can keep an eye on the disease, monitor it, not actively treat it. And then if they develop problems from the disease, say side effects, we can treat the side effects, but we don't put them through definitive treatment to cure because those definitive treatments may not be necessary. On the other hand, some patients are eligible for active surveillance. I have a large group of patients in their early 50s, for example, who have a very long life expectancy, who have a small amount of non-aggressive prostate cancer. And those patients don't always require treatment, but we have a pretty regimented way we keep an eye on them with blood tests, periodic repeat biopsies of the prostate, and we also have some new molecular tools that are proven to be very helpful. There's a test called Oncotype DX, and it comes from I came from the Cleveland Clinics where I used to work. I was one of the vice chairmen. And the Cleveland Clinic and the University of California, San Francisco collaborated on this test where we looked at the expression of 17 different genes that help determine whether or not that prostate cancer can be dangerous to that patient. And so when someone's eligible for active surveillance, we can take their biopsy slides, send them out to the company, and they will actually determine the gene expression. And then we can talk to the patient and say, gee, this is a prostate cancer that we may not never need to treat, or it's one that potentially could be dangerous and need to treat it.
Now, you mentioned all people, as we age, are there certain risk factors that make a certain person more likely to experience this?
So African American men in this country are one group that we pay particular attention to because they're more likely to get prostate cancer. They actually have the highest chance of getting prostate cancer of anyone in the world. We don't know all the reasons that go into that, but they're a definite risk group that we like to screen earlier, starting at 40. The other group that's at risk are patients who have a first or second degree relative with prostate cancer. That's another group we like to screen earlier.
Okay. Well, you mentioned some new technology. Are there other new things on the horizon that we may want to know about?
So there's a lot of new things that are on the horizon. As my specialty is urology oncology, which is cancer of the urinary tract. And at the Society of Urologic Oncology meeting that I go to at the National Institutes of Health every year, we've been discussing lots of new technology. Much of it is related to gene expression. And so we're going to transition from pathologists that just look at the slides and tell us, the grade of the cells, whether they're aggressive or non-aggressive, to the actual gene expression of the tumor cells themselves to determine whether or not that prostate cancer is a dangerous one or a not dangerous one. So that we're really just taking off. We're right on the threshold of a really new era that's exciting for us.
Well, great. Well, how do you or maybe just regular internal medicine doctors or family practitioners, how do you begin this conversation with someone about starting that screening process at those ages that you mentioned?
So typically it's done by primary care doctors, but in urology sometimes we see patients who don't have a primary care doctor, and I discuss with them. We talk about the risks and benefits. Like in everything, there's risks and benefits, but screened populations have a 40% lower death rate from prostate cancer.
That's pretty good, pretty good information there. Well, before we wrap up, if any of our viewers want more information about these screenings or about prostate cancer, where would you suggest they go as a resource?
It's always best to start with their primary care doctor that knows that patient the best. We're always happy to serve people at Baptist also.
Great. Thank you very much. I appreciate it.